My name is Michelle Ndwele, and I'm the Senior Director for Health Promotion with the Arthritis Foundation. It is my pleasure to welcome Dr. Karen Costenbader. Dr. Costenbader is the Director of the Lupus Program in the Division of Rheumatology, Inflammation, and Immunity at Brigham and Women's Hospital, and she's also a Professor of Medicine at Harvard Medical School. Her research focus is rheumatoid arthritis and lupus, and she has trained over 30 doctoral and postdoctoral fellows. Welcome.
Oh, thank you very much for the invitation. It's nice to be here. Nice to meet you.
So I am sure so much has happened in rheumatology, despite the fact that we have all been dealing with COVID. So while COVID is such a focus, I'm sure there are great things that we are going to talk about in rheumatology. So let's start off with the recent FDA warnings around JAK inhibitors. For patients who are on these medications or maybe newly diagnosed and considering them, what does this mean?
Good question. There is definitely a lot of hubbub about JAK inhibitors, and I've been talking to my patients a lot about it. I think so. They are a class of medications that we were really excited about. They're smart medications that are targeted at this one molecule, and they're oral medications, and they do work really well in rheumatoid arthritis. They work well in a variety of our diseases. So actually, last year at the ACR, the great debate was whether they should be started first or whether patients should be started first on other biologic therapies like anti-TNF, especially rheumatoid arthritis patients. So there was a lot of discussion, and one of the nice things is they're oral and they work fast, and patients love them for that reason. So the backstory is, though, then when the first JAK inhibitor was approved back in 2012 in the United States by the FDA, Food and Drug Advisory, they mandated a long-term extension study. So it was approved for rheumatoid arthritis in 2012, tofacitinib, and people have been taking it since then. But they said, we want to see long-term data about the safety, because there was some question about safety. There's always questions about safety about new medications. So the question about safety in terms of blood clots in particular was what they were worried about at that time, but they looked at cardiovascular disease, cancer, blood clots, and death overall, and infections. So they're worried about everything that long-term might show up in a study, but doesn't show up short-term when people just take it for a year or two. And so they needed a very big study. So Pfizer agreed to do a surveillance trial, which was, I think there were 4,362 patients with rheumatoid arthritis that were followed for 4 years, and it was a randomized trial, and they were followed for a long time. So they were all patients with rheumatoid arthritis. They all had at least one cardiovascular risk factor. So they were smokers, or they had a hypertension, or they had a family history, or they had something that made physicians worried about their cardiovascular risk. And they all were taking background methotrexate, which is usually the starting medication, and then we add on one of these medications. And then they were randomized to get tofacitinib, the same JAK inhibitor we're talking about, or an anti-TNF medication, either etanercept or adalimumab. So this was called a non-inferiority trial, and they basically had to prove that it was not worse than anti-TNF, that it didn't have any increased risk. And we haven't seen all the published peer-reviewed data yet, but the top line results are out, and we're waiting for the peer-reviewed publication. And the top line results of after 4 years showed that it didn't meet this non-inferiority margin. It actually was a little worse. It was a little worse. It wasn't a ton worse, but the incidence rates for major cardiovascular events and for cancer were both a little higher than with anti-TNF. And there's been a lot, and so it was beyond the margin where they say they're basically the same. The non-inferiority means they prove it would be the same. But they had to prove that it was not inferior, that it was at least as good. But they didn't prove it was at least as good in terms of safety. They proved it was a little worse. So we're all scrambling. The FDA has put out 3 different communications about it this year, last in September. And in September, they put out a communication that said that they're putting a new black box warning. So that means, on the label, there's a box, and it's called the black box warning. It's a warning to patients and to physicians that says that these medications may increase the risk of cardiovascular disease events, and they may increase the risk of cancers, and also blood clots. They included they're putting these black box warnings at this point, although we haven't seen all the data and the trial was only in patients with rheumatoid arthritis taking tofacitinib, they're putting it on all of the JAK inhibitors. So there are other JAK inhibitors. There's baricitinib and upadacitinib that are out there in the United States as well. So it goes on all of those, and it's for any indication, not just rheumatoid arthritis. So the FDA is really being very conservative and warning people. And the black box warning says, talk to your patients about the potential increased risk. So this risk was seen over 4 years in a lot of people. They all had risk factors. That's one thing, cardiovascular risk factors. And they probably had cancer risk factors too, because if they're smokers, then they have risk factors. There was a lot of, there was lung cancer and lymphoma were the two most common. So I think it says talk to your patients about it. Think about other medications if they have a lot of cardiovascular or other risk factors, cancer risk factors. It's not a huge increased risk. For malignancy, the hazard ratio is 1.48. So it was statistically a little bit higher, 0.48, maybe 48% higher over this time period than the comparison to anti-TNF medications. And for malignancy, it was 33%. So I'm worried about it. Patients are worried about it, but they're still really good medications. There are a lot of physicians saying, let's wait to see the peer-reviewed data. Let's wait to see it all. Let's wait for other studies and other populations with other JAK inhibitors. But I think we need to talk about it. We need to think about it. We need to screen for malignancy, screen for cardiovascular disease. I have had patients that really just don't feel comfortable on them because they think, well, just with rheumatoid arthritis, I'm at increased risk, because we know that patients with rheumatoid arthritis have increased risk of cancers and cardiovascular disease. So they would rather, a lot of them have already been on anti-TNF and changed this new medication because it was really convenient and oral, and now they're changing back. So that's a long answer to your question, but it's a complicated story and it's evolving. And I think in the next month or so, we will have the full publication of the peer-reviewed results. I'm sure they're going over them with a very fine-tooth comb to make sure that everything's right before they release all the data.
Thank you so much for giving all that background, because a lot of times patients see the headlines and really understanding the context and some of the kind of what do the numbers mean. It's very important. But of course, the key takeaway message is how important it is to have the conversation with your doctor to really screen for risk factors and make an informed decision about the risks and benefits of using these, as you said, very convenient medications for a lot of our patients. Which takes us to our next conversation around optimizing clinical care, because we know that's so important for doctors and patients as well. So could you share some of the learnings around treat to target this year as we look at the year in review?
So I think there's been a lot of interest in treat to target. And what treat to target means is that we have in mind, and there are committees of rheumatologists that sit around and make up these targets, that we want people to be in remission. So they're often very patient-centered, and patients with the disease will be involved in saying, what's the target? What should we be shooting for? And we're in a really great place now in arthritis because we have really effective medications. So we're not just trying to quell the immediate flares and getting people, back to work and functional. We really want them to be in remission and really well controlled. So that's the goal that we talk about with our patients. We want you to have, really no symptoms. We want you to pop out of bed in the morning and not be stiff. We want you to, not have side effects from medications and not have any tender swollen joints and things like that. So in many diseases, in rheumatoid arthritis and ankylosing spondylitis and lupus, etc., we have these targets in mind of keeping the disease under control. And then there have been trials of how well how well we can do this and how much it adds to outcomes. So there have been trials, and I think they're very laudable outcomes. I think that should still be the goal that we aspire to, no matter what, to keeping our patients in remission. And is it possible? And does it prevent long-term damage? We think that that's the key. I mean, patients feel good, and then long-term their outcomes are probably going to be better too. They're not going to get joint damage. They're not going to get, medication side effects. Hopefully, we have to balance all these things. So this year, there have been other trials of tight control, meaning we're trying to keep the disease activity really tightly controlled and tamped down. and treat to target strategies. And there are different treat to target strategies. And this year there was a big trial that was published in Annals of Rheumatic Disease, and it was called the Tycho SPA trial. And it was for people who had axial spondyloarthritis. Arthritis affecting mainly their spine, a kind of inflammatory arthritis of the spine. And they had a very specific outcome for their treat to target strategy. Was patients were seen every 4 weeks, and then they had a target disease activity of getting it below a certain number, and that was compared to usual care. And this was a trial that was conducted in Europe, in France, and the Netherlands, and Belgium. And then they had a primary outcome of, did it improve the health index? Did patients feel better at 48 weeks? The patient reported, and keeping them in low disease activity. And then they also looked at other outcomes, and they looked at ACES response criteria kind of thing, other predefined criteria. And also they looked at quality of life, and they looked at cost. And so the trial was interesting because we all think that, well, at least most of us are convinced that treat to target is the way to go, that patients will like it, but actually it failed to meet the primary outcome. So there wasn't a big difference in the primary outcome of this outcome called ACES Health Improvement Index of greater than 30% at 48 weeks. But the safety was similar, and it did add some quality adjusted life years. So quality of life was improved, and it saved some money, actually, 472 euros, because it was conducted in Europe. And the kicker here is that it was actually all the centers that were involved were axial spondylitis expert centers. So we think that maybe the patients in those trials, even though they were randomized to getting standard of care, the standard of care might have been very good. So we didn't see the difference. We still, it's a shame we didn't see a difference. It's really important to have all these trials conducted so we know what we should be shooting for. How should we keep people in remission? Well, how should we do treat to target? How should we do tight control? And what does it add in terms of patient outcomes and cost and safety and quality adjusted life years, all those things. So that's this year. There were other studies as well of tight control out there, but this is the one
That's very interesting to hear the outcomes. And I'm wondering if, because it's a European context, the every 4-week appointment was a lot more manageable, and that may be the reality for a lot of our patients in the US in terms of getting the time off.
Right,
to be
exactly.
Frequent. And maybe that's where the role of Tele-Rheumatology could be useful in the US in the context.
Very good point. Very good point. Because we don't see normally, and I don't know what the in Europe in those centers how frequently they were seeing patients. We do think that the more frequently we see patients, the tighter we can control their disease. We see them very frequently. We check in with them. Oh, you're having a flare. Oh, you're having these symptoms. We can adjust the medications. But often, the realities are we're lucky if we can see people every 3 or 4 months. With COVID, there's been a move to telemedicine. We can't get people are afraid to come in, or they can't come in. So I agree. That's a great thought. We have been pushing for more telemedicine and checking in a little bit more frequently with your doctor, doing a telemedicine visit, every other or something, a little more frequently might be a great idea.
So let's talk a little bit about the tapering approaches for DMARDs. Are there any new learnings around that?
Well, I think for rheumatoid arthritis this year, yes, there were several studies, and I talked about one. There were several trials because so once we get somebody in remission, and we talked about how effective the new medications are, the JAK inhibitors and the anti-TNF medications, especially in rheumatoid arthritis now, we have a good problem to have that we don't know, once we have somebody feeling great, popping out of bed in the morning in remission, then what? Then how long do you continue the medications? And patients are often saying, well, I'm worried about long-term side effects, as they should be, because we talk about potential side effects. And so we're always, titrating and trying to balance the risk benefit. If we start decreasing your disease modifying therapy, are you going to have a flare, and would it be worth it or not? Should we do that? So there were multiple studies and trials over the past few years that have looked at how to handle our patients with stable rheumatoid arthritis in remission, because it's a big question. I mean, people ask all the time. I've been in remission for X number of months or years, and on this dose, I'm doing really well. Do I need it anymore? I reviewed a study in which it was conventional synthetic DMARDs, so that's methotrexate and leflunomide, sulfasalazine, hydroxychloroquine, not any of these smart new medications or biologics or injectable medications. But they did a trial. Again, they took patients being seen in the clinic in different centers in Norway, 10 different sites in Norway. And they did a study where people were randomized 1-to-1, or 160 patients with stable RA. And some people stayed on the full dose of whatever they were taking, methotrexate, leflunomide, and the other people cut their dose in half. And they followed them for, let's see, how long it was. It was 12 months. Sorry, they followed them for 12 months and to see who would flare. And that was the main outcome was, are they going to have flares? Are they going to have worse disease outcome if they cut their disease? Because they've all been stable, so maybe they don't need it anymore. But sure enough, the people who had their medication cut in half had 4 times the risk of having a flare. And so the risk was 25% versus 6%. So they stayed on a stable dose. It stayed at 6%. And then they looked at a bunch of other secondary outcomes, and across the board, reducing the dose was the inferior strategy. Flared, they had other outcomes. So, and they looked at in people just taking methotrexate versus taking multiple things. And so this has been this study and others like it have been reflected in the new 2021 American College of Rheumatology treatment guidelines for rheumatoid arthritis. That there they have a big group of experts in rheumatoid arthritis opine, get around the table and think and hash out all the studies and all the evidence and make treatment recommendations for physicians and patients to follow. And there they recommend conditionally, but meaning they're not overwhelming, but they say that the evidence is pretty strong that if patients are stable in remission on their DMARD for at least 6 months, as RA patients, they should continue rather than taper. So, but people always want to taper, but I think this helps us to say, well, you're at an increased risk. These were patients who were stable for a year, and then they started going down, and we don't know a lot about the details. Every patient is different. So if they've had really active disease in the past, really hard to get under control, that might be different, and they might be more reticent to cut, physicians maybe, to cut down the dose than if it was more benign disease. It was milder disease. They came into remission really quickly on the DMARD. So everybody's different. But I think that these kind of data do help us to inform patients that, well, if we cut, the data do show you are going to flare.
I think it's really important to have this kind of information as a part of that risk conversation, because I have an autoimmune disease myself. And yes, as a patient, I can say that our question always is, once you get to remission, is, can I taper? So the context and comparing the groups is just important information for us to have. And I'm glad that you raised kind of where a patient started at, whether it's, more higher disease activity or more benign disease activity. Those considerations are important as a part of the larger tapering conversation.
And it goes back to the conversation about JAK inhibitors too. All those the informed decision making where we're going back and forth and talking about it. People are, I want to stop my JAK inhibitor right now because they're worried about the side effects. Yeah, but we do know that if you just stop or cut it, you're probably going to flare. So let's talk about alternatives. There's the risk of flare and the risk of not having completely controlled disease. But we are in a nice place that now we have so many new medications that we can keep people in remission, which is great.
All right. So you mentioned medication. So let's talk about some of the new medications for, I believe, lupus and vasculitis.
Yeah, so that's the exciting new positive news this year. We've had at least lots of trials, and I did try to stress clinical trials in my talk, because those usually have the biggest implications for care. Observational data can be flawed, but a clinical trial, hot off the press, proves something in a different way, really test something. So these are both for diseases that have been pretty hard to treat, and we treat them with high doses of steroids, and that can be pretty toxic. So there are two medications. They're both oral medications, and they're for ANCA-associated vasculitis, which can be a horrible disease, vasculitis, and for lupus nephritis. So the first is avacopan, which is an oral complement inhibitor. It's a new kind of medication, and it had looked good in earlier trials, and now they had a year-long trial done in multiple centers, and the primary outcome, so people were randomized to get this new medication, avacopan, which is oral, or get prednisone. It was a pretty rapid prednisone taper. The idea is that for both of these medications, they would be able to spare people the prednisone toxicity. We use too much prednisone and too much steroid in rheumatology historically, and there's a big impetus to get our patients off faster because we know about all the horrible side effects, but they work fast and they do work pretty well. So in both of these studies, they're kind of the comparison. So here, this was add-on therapy to what people were getting standard of care for their ANCA vasculitis, and was compared to a rapid prednisone taper. And I talked about non-inferiority trials before. So they tested both non-inferiority and superiority. They tested first, is it worse than, any worse than, or better than, at least as good as the prednisone, and then is it actually better than prednisone? So, and they looked at remission from disease. So we also talked about remission, not having symptoms. That's the goal. So the remission definition was pretty strict, and they looked at it at 26 weeks, half a year, and at 52 weeks, a whole year. So at the first landmark of 6 months, it looked like it was not worse than prednisone, but it wasn't better than prednisone. But then in terms of remission, but in terms of sustaining remission, being a remission at both time points, 6 months and 1 year, it was better. And it was both not worse, and it was better. So that's great. And the serious adverse events were the same. And they also looked at relapses. So people, once they got into remission, who stayed there. And it was 10% at 1 year of the people who were randomized to get the avacopan new medication, and 21%, double that, in the people who were randomized to get prednisone. And so those are really strong results. And the exciting thing is that right before I recorded my talk, actually, at the beginning of this month, the FDA approved avacopan for the use for ANCA vasculitis. So a new medication for ANCA vasculitis, and it looks really promising and really exciting that we might be able to get our patients off steroids faster and have better outcomes, keep people in remission without relapse. So that's exciting. And then the other medication is called voclosporin, and it also is an oral medication, which is exciting. It's a calcineurin inhibitor. So we do have oral calcineurin inhibitors that we use for lupus nephritis. Cyclosporin and tacrolimus are two in that category. But this is a new one that was specially developed by the company that says that it doesn't need as much intensive monitoring. And it also looked pretty good in earlier studies, earlier trials, but this was also a big phase 3 randomized controlled trial to test it in lupus nephritis. So again, it was an oral medication, which was an add-on therapy on top of background of care, a standard of care, and then really compared to steroids, how fast people can be taken off steroids. And this was for patients who have pretty active lupus nephritis on biopsy. More than half of them were already getting mycophenolate mofetil. It's the start of it. And then they had the primary outcome was at 1 year, and it was a complete kidney response, complete renal response. So it looked better, was a complicated composite of multiple different measures of kidney function. And then they had a lot of secondary outcomes as well. Because in lupus nephritis, the main risk is you can lose your kidneys, your kidney function. So, and this trial was really positive. It met all of its primary and secondary outcomes. Very exciting. And there had been a concern about actually death is in the first trial, earlier trials. There have been a few more deaths in the voclosporin arm that was not seen here. And so the primary analysis was at 1 year in the voclosporin group, where 23% of people in the placebo group versus 41% of people in the voclosporin group made the complete renal response criteria, which is great. So their kidney inflammation went into remission, which is the goal, and then all the secondary outcomes, and in particular, which is how much protein they're losing in their urine. In lupus nephritis, we don't like to see a lot of protein in the urine. It means ongoing damage in the kidney. We have to get that under control. And the voclosporin was really effective in getting the proteinuria, the protein in the urine, under control really quickly, much quicker than with the just prednisone alone. It was like 29 days. So within 1 month, it was a 50% reduction in the protein versus 3 months. And the side effects were balanced and all the subgroup analyses were favorable. So the other good news is that the FDA approved voclosporin for the treatment of lupus nephritis as an add-on to additional medication on top of standard of care in January of this year. So 2 new oral medications approved by the FDA for 2 really hard to treat diseases that we treat with too much prednisone. And both are add-ons to standard of care. Everybody's insurance is different, or lack of insurance is different, and unfortunately it leads to great inequities.
Yes. Well, Dr. Costenbader, as we close out this conversation, you raised that important word of inequities. So that will take us to our final topic around disparities in rheumatic disease, especially with regard to both pain experience and intensity for underserved populations. So could you share with us some of the learnings from this year and what some of the thinking is?
Sorry. There have been a lot of studies, and I think that COVID has brought it up, but we unfortunately have disparities that we've been well aware of in rheumatic diseases for many years, in many of our diseases, and not all of our diseases. And we have disparities in the United States in healthcare access, as we were discussing, and medication access. Here, I didn't talk about clinical trials because this is not a subject that you can randomize people to. So I talked about 2 observational studies. And the first used data from the American College of Rheumatology, has a big registry called the RISE registry. And it's the Rheumatology Informatics System for Effectiveness. And it's been collecting data from actual rheumatology practices, private practices and academic practices and everywhere in between, all over the country. There, in this study, there were 109 different American rheumatology practices that contributed data. And they did a very straightforward analysis. They looked at almost 84,000 adults with rheumatoid arthritis who are being treated in these rheumatology practices across the country. And they all had zip codes. So they calculated the zip code for where the person lived, and they calculated what's called the area deprivation index, which you can calculate from US Census data based on that zip code. And they use that as an indicator of neighborhood poverty. So they don't have exactly the person's socioeconomic status or their own indicator of poverty, but they know that they live in an area which is associated with more or less area deprivation of poverty. And then they also had, from all these practices that had reported how they treated patients and a lot of other information about their rheumatoid arthritis patients, functional status measures. So when you go to the rheumatologist, often you fill out a survey about how you're doing, and there's a variety of these. There's a health assessment questionnaire called the HAC, or more variations on this, HAC2, multidimensional HAC, but they're all measures of functional status. Can you do this? Are you able to do that? And so then we can track them over time if you're having trouble, putting on your shoes, doing different tasks or functional status. So they just the investigators here just looked at where you lived in your socioeconomic status area and your functional status. And they adjusted this for a lot of other things that might be related to this, but they were looking at, is there a relationship between living in an area with more or less poverty and your functional status and your rheumatoid arthritis? And they saw across the board, by whatever measure of functional status they had, that where the people who lived in the lowest SES areas, lowest socioeconomic areas, had the worst functional status. And the people who lived in the highest had the best. And this was after adjusting for age, sex, race, ethnicity, medications, other things like that. And then they had a sub-cohort of these people, about half of them, about 36,000 people, had more than 2 health functional status measures over at least a year. And so then they said, well, are they having functional decline? Yes, no. Is it worse from visit 1 to visit 2 or better? It was pretty easy. Yeah, and they looked at that across the socioeconomic status areas, and they saw the same gradient. If you lived in a low SES area, you had a much higher probability of going downhill in terms of functional decline. And I think that these data are really, well, they're sobering, they're important for a couple of reasons. One is these are disparities that are seen in rheumatology specialist care. So we can't say it's because people can't get to a specialist, because here they're already seeing specialists. These are seen across the country in the United States. We know we have these disparities. I think they're very important, but unfortunately, they're not totally unexpected. We have these disparities in a lot of diseases, a lot of outcomes. They're definitely multifactorial, and we need to get to the root causes of them. That people who live in areas that are marked by more, this is an area deprivation, more poverty, do worse from many, many things. And there are many things they couldn't control for. We know that stress and air pollution, and there are many, many things that are different in those areas. Access to green spaces. It's amazing what people study, and they're related to functional status and functional decline. And this country does have, as we were saying, inequities and disparities. And I think studies like this that really put these data out for people and make it very apparent that these gradients exist are important, because we need to get to the bottom of them. So that was the first study that I talked about. And then there was another study that also used a large observational cohort, and this is in osteoarthritis. And here they looked at disparities from a very different angle. And it's known that there is a gap, there is a disparity already between what patients report as knee pain from osteoarthritis and what can be seen on their knee x-ray by a radiologist who reads a traditional score based on narrowing in the joint and osteophytes, and they give it what's called the Kellgren-Lawrence scale of severity. But there's not a very good correlation between what the patient experiences as pain today and how bad it is on the x-ray by that score. And we know that disparities, and there's a disparity in the disparities, it's even bigger gap for underserved populations. So for people who live in low SES areas and for Black patients, this gap is bigger. We don't know why, but they may have a lot of pain and the x-ray is read as not that bad. And then we think that may contribute to some of the big disparities we see in access to the right therapy there, because the doctor looks at it and says, well, your x-ray isn't bad, and so then doesn't offer them a total knee replacement. You're not ready for it yet. Look, it's not bone on bone, it's not horrible, it's not stage 4. So here they took data from the Osteoarthritis Initiative, which is a big multi-center longitudinal observational cohort in the United States, where there are patients who already have or are at very high risk of having knee OA. And they all had knee x-rays, and they also had self-reported measures of their knee pain. And they compared a radiologist's traditional Kellgren-Lawrence scale score to a fancy new exciting thing called a deep learning artificial intelligence algorithm to estimate knee OA pain severity. So they had and it was a very sociodemographically diverse cohort, 58% Black, 58% female, 17% Black, 38% low income, and 25,000 x-rays. And they used artificial intelligence to look at many different x-ray features and trained what's called a convolutional neural network. And don't ask me to explain all that because it sounds very fancy. I don't know exactly, but they used many different x-ray features to predict reported knee pain. So the outcome was still knee pain. And then they had a validation set where they retrained to see if it would work. And then the primary outcome of the study was actually the disparity by subject race, and by socioeconomic status between what they reported as self-reported pain and X-ray findings by either the traditional radiologist calling the Kellgren-Lawrence scale or this new fancy AI algorithm. And the cool thing was that the radiologist scale grade, Kellgren-Lawrence grade of the OA severity on the X-ray, as we know, was horrible at predicting pain. It was only explained 9% of the disparity between pain, Black and non-Black patients in their reported pain and the reading. So it didn't explain much. But the new fancy algorithm explained 43% of the difference. So if, and they also had similar results by socioeconomic status. So something about other features of that the AI algorithm was able to pull in better predicted pain. So it was pretty cool that it more accurately predicted the knee OA severity and accounted for more of the unexplained disparities by race and socioeconomic status. And then the authors go on to say that maybe correctly identifying patients with severe pain from X-rays might reduce disparities in treatment and access to total knee replacement. And I think that's a great idea, but that definitely remains to be seen. I mean, we're not using these yet, but wouldn't it be nice if we had a better way to actually predict? I mean, we could listen to patients who say they have a lot of pain. That's the first thing. But often surgeons also want something, to hang their hand on and say, like, I can tell on the X-ray that you have really bad knee OA and you need a knee replacement. So maybe they need to be reading their X-rays in a different way. And so that's the implication of that study.
All right. Well, thank you so much for that background, because it just reminds one of the priorities at the foundation is elevating the patient voice. And while we understand and respect, the value of empirical data and kind of the power of a number, it's really important what you shared, that the rheumatology field and orthopedics by complement are really understanding that there are other ways beyond some of the traditional methods that have been used, and that is being explored is positive news for patients.
Exactly.
So thank you so much for providing that background and that.
I couldn't agree more. Yeah, listening to the patient and elevating the patient voice is extremely important, crucial.
Okay. Well, Dr. Costenbader, thank you so much for taking the time to walk us through 2021 in rheumatology and sharing some of the background and context for some of the key highlights. So thank you so much for taking the time today.
Thank you. No problem. It's been my pleasure. Thank you very much.